Once again, good evening, good afternoon, and good morning to everyone. We will start today's EPI-WIN webinar, and today's EPI-WIN webinar is hosted by WHO EPI-WIN, and we will be having a topic on the Chikungunya, and this is the start of the arbovirus series that we will be doing in the future. As we are already a little bit late, and I don't want to take floor from our great presenters for today. We will have Dr. Sylvie Briand, we will have Dr. Maria van Kerkhove, we will have Dr. Diana Rojas, we will have Professor Thomas Scott, and we will have Ms. Thais Dos Santos from our PAHO office as well, and they can present themselves as well. So having said that, over to Dr. Sylvie Briand. Thank you.
Thank you very much, Lubika. And good morning, good afternoon, and good evening, everyone. So I'm Dr. Sylvie Briand. I'm the director of the Epidemic and Pandemic Preparedness and Prevention Department at the World Health Organization. And I would like to welcome you to this Wednesday WHO webinar, WWW, on EPI-WIN channel. So today, as Lubika said, we will talk about Chikungunya. And for us, it's a very important disease because in our area of work, epidemic and pandemic preparedness and prevention, this disease has become more important over time. And other speakers will talk about the recent outbreak we have seen, especially in the Americas. So Chikungunya is a vector-borne disease. This means that the Chikungunya virus is transmitted by a living organism to human, thereby causing illness. And in the case of Chikungunya, the vector that transmits the virus to human is Aedes mosquito. It's a family of mosquito. And Aedes mosquito also are vector for dengue, yellow fever, and Zika viruses, all of which can cause also epidemics. Therefore, the Aedes mosquito is of a significant interest for public health, in particular for the preparedness and prevention of epidemics and pandemics. And currently, almost 4 billion people are at risk globally for Aedes-borne diseases, such as dengue, chikungunya, and Zika. And this number continues to increase because of the habitat of the Aedes mosquito is expanding due to various factors, but in particular, climate change and urbanization. Aedes mosquito favor warmer climates and human settings where there are ample protected space to hide, such as under tables, behind curtains, and collection of still and relatively clean water in which to breed. Even in areas where there have been previous epidemic of chikungunya, such as in the Americas since 2013, population level immunity is not high enough to prevent current outbreaks. The virus is spreading into new areas that has previously been spared, and this increase in the America of chikungunya and other Aedes-borne diseases such as dengue is worrying. The number of chikungunya cases reported in the first 4 months of 2023 already surpasses the annual number of cases reported by year from 2017 to 2022. So I will tell you why we are concerned. Even though the mortality associated with chikungunya is low, the patient does experience severe joint pain and relative disability that can last for months. So the impact of the disease is therefore very high, as the acute illness can be followed by chronic disabilities related to joint pain and mobility, and this can significantly affect the person's ability to move, work, and take care of themselves and others. In addition, there is an impact on health system. When we have an outbreak or an epidemic, in some countries in the America, a relatively low proportion of cases at risk of severe disease translates sometimes in really a large number of patients that require care in healthcare facilities. Therefore, the health system can be completely overwhelmed during an epidemic, and other diseases that are also important to take care of cannot be attended at the same time. So the current localized outbreak of chikungunya should be seen, of course, as threats, but also as opportunities to learn about vector-borne diseases, to improve our preparedness for them, and to refine the methods of prevention. As with other vector-borne diseases, preparedness requires an understanding of the vector, its habits and habitats. It will then be possible to predict which geographic areas might be at increased risk and to take measures to reduce the mosquito-friendly spaces. One aspect of prevention includes also individual prevention, which means avoiding mosquito bites through the use of appropriate clothing that covers most of the body, mosquito repellent, and use of bed nets. And furthermore, healthcare systems can increase their capacities to diagnose and treat chikungunya as early as possible, while also providing support to patients suffering from long-term consequences of the disease. And it's our hope that this webinar will build some understanding about chikungunya. And I would like to thank all the speakers for sharing their knowledge, and in particular, Professor Thomas Scott for making the time at a very bad time zone, I understand, but just to share with all of us his knowledge on vector and this disease. So thank you very much to all of you. And I give the floor now back to Lubika, who is moderating, or Diana, who is moderating this webinar. Thank you.
Yeah, this is a team effort. Thank you, Sylvie. So yeah, I will start and then I will hand over to my colleague, Diana. Okay. So over to Maria for her remarks. Thank you.
Thanks, Lubika, and hello, everyone. Good morning, good afternoon, good evening. Thank you so much for highlighting chikungunya and the latest WWW EPI-WIN seminar. I love that, Sylvie. So I'm going to add on to what Sylvie mentioned in her introduction. The current outbreak of the chikungunya outbreak in the Americas highlights the importance of emerging and re-emerging viruses of zoonotic origin and the need to maintain a broader view of the ecology that facilitates their introduction and propagation. For this reason, as Sylvie pointed out, interventions to combat Aedes-borne arboviruses and other epidemic-prone infectious pathogens need to be planned and implemented across sectors, across disciplines, and this underscores the critical importance of using a One Health approach. As you know, we continue to be faced with formidable infectious disease threats, but our time, experience, and hard-learned lessons, including those that we are learning and applying from COVID-19, have resulted in having smarter strategies and tools available to all of us to prevent, detect, and respond. WHO and with our partners are developing models and risk maps of infectious disease hotspots around the world to better identify where to invest critically limited resources and build capacities for now and for the future. Countries all over the world are committed to investments in the development of epidemic preparedness plans and have greater appreciation for their importance of doing so. PCR diagnostic capacity has expanded substantially in most countries all over the world, especially in the last 3.5 years for COVID, but built for COVID can be used for other infectious pathogens like chikungunya. This expansion is most impressive at subnational levels, enabling timely local confirmation of pathogen detection and disease transmission. This is a particular advantage for chikungunya, where high viremia remains detectable for at least a week after the onset of illness. Another advance in the last 3.5 years is in genomic surveillance. The advances in genomic surveillance allow for a greater understanding of the circulating viral lineages and the potential impact on non-immune populations. And we encourage countries to use these capacities that were originally built for COVID-19, building on the capacities for influenza, building on the capacities for HIV, for polio, for other infectious diseases, to use these advances in molecular diagnostics and genomic surveillance to understand other pathogens such as chikungunya and other mosquito-borne viruses. Technology platforms for medical countermeasures, such as vaccines and medical therapies, are able to be scaled more rapidly than ever before. Now, in March 2022, the World Health Organization launched a global arbovirus initiative to strengthen coordination, communication, capacity building, research, preparedness, and response necessary to mitigate the growing risk of epidemics due to arboviral diseases. This effort has grown and increased partnerships across public health agencies, NGOs, and academic institutions. The initial focus is on Aedes-borne arboviruses, but the scope is expanding to include those transmitted by other arthropod vectors and causing a range of different clinical features, including encephalitis. The planning and implementation benefits from these inputs from subject matter experts have formed the Technical Advisory Group for Arboviruses, which includes representatives and expertise from across the globe. Our hope and our intent is that through implementing this and complementary initiatives and programs from the global to the local levels, we will move from a posture of reactive outbreak response to that of building capacities during and after periods to better mitigate the impacts, to prevent them from happening in the first place as much as possible, to better mitigate their impacts and reduce morbidity and mortality moving forward. Thank you so much for joining the webinar, and back to you.
Thank you, Maria. Thank you very much. Just a kind reminder to everyone online, we have interpretation, and you can go on a little globe there and choose the interpretation on Spanish, Portuguese, or French as needed. And over now to Diana as our next presenter. Thank you.
Thank you very much, Jubika, and good morning, good afternoon, and good evening. I am Diana Rojas. I'm the technical lead for Zika and Chikungunya in the Epidemic and Pandemic Preparedness and Prevention Department. So let me get started with an introductory video about Chikungunya. So Ingrid, if you can please share the video. Please do not forget that the interpretation globe is there in Portuguese, French, and Spanish. And please use the chat to introduce yourselves and tell from which country are you joining.
Here.
We can hear.
Here.
Well, maybe I can
we'll
share my
yes.
screen. I can start my presentation while we figure out about the...
I apologize, I'm having trouble with the sound sharing option. Thanks.
No problem. So let me get started with a brief background and a global overview of Chikungunya. Can you see my screen now? Okay.
Yes, perfectly
So
well. Thank you.
The name Chikungunya comes from the Makonde language. That is a local language in Tanzania where Chikungunya was found for the first time, which means to become contorted, because that is the position that the Chikungunya patients usually have due to the very severe joint pain and the disabilities that are carried with this disease. As a Chikungunya virus is an alpha virus, and it has 4 different lineages, which are located in different parts of the globe. As Sylvie mentioned, the main vector are the Aedes mosquitoes, Aedes aegypti or Aedes albopictus, which are widely distributed now. Most of the people that are infected with Chikungunya will develop symptoms, around 70% of them. And the symptoms are high fever, severe joint pain, arthritis, stiffness, mostly in the hands and in the small joints, and rash. And they last usually for 2 weeks, but some people can have these symptoms up to 3 months. That's what we call the subacute Chikungunya, but around a good proportion can still have symptoms for more than 6 months or even years, and that's what we call a chronic disease. And as it was mentioned, the main disease burden is due to the chronic disabilities and the severe impact on patients' quality of life. So just imagine any of the people that are in this webinar completely healthy, and after chikungunya, you are not able to hold a pen, you're not able to type in a computer, you're not able to even hold a fork and a knife to eat or to cook or even type in a cell phone. So that's kind of the disabilities when the hands are the main joints that are affected, or well, it could be the knees or it could be the feet, so people can walk. The severity vary by age, and newborns, young infants, and elderly are at greatest risk. And also people with comorbid conditions or with pre-existing conditions such as hypertension, diabetes, or in people that are immunocompromised. Here is a brief summary of the last 5 years or the most recent outbreaks of chikungunya. So even with the pandemic, there were some chikungunya outbreaks. So in Congo, there was a large outbreak with thousands of cases in 2019, in Chad with hundreds, thousands of cases in 2020, in Cambodia, one of the largest chikungunya outbreaks in that region at the end of 2020, beginning of 2021. And in 2021, also there were outbreaks reported in India and Djibouti. And currently, there is an increased number of cases from the end of 2022 to the beginning of 2023 and in the Americas, and Thais is going to do a deep dive on the situation in the Americas. So let me explain quickly some of the drivers of transmission for chikungunya. So we have the vector drivers, the drivers that are related with the virus, and then the ones that are related with the human host. So the ones that are related with the vector, we have the environment, as it was mentioned, so temperature, precipitation, and humidity have an impact not just in the mosquito densities, but also in the incubation period of the virus inside the mosquito. And with climate change, of course, we are seeing the mosquito in areas where it was not present before, but also the patterns in endemic areas have changed. So the seasons are changing. It's not like what we're used to see in the last 20 years. The seasons are starting earlier or are starting in a different time. Another driver is the absence or reduced vector control programs due to different circumstances, and with the COVID-19 pandemic and the restrictions, there were a lot of the countries had limitations to do vector control, like the visits house to house to do vector control due to the restrictions, insecticide resistance, the environmental adaptation of the mosquito. Also related to the virus, as I mentioned, there are 4 different lineages, and depending, some of them are more compatible with Aedes aegypti, some others are more with Aedes albopictus. And then, of course, these are RNA viruses, so they are mutating, and at any point we can have enhanced transmissibility. And in the human host, the population immunity, the population movement. So now travel is back. We are moving around the globe. So the probability of introduction to new areas is there, and even the if there is an area with high transmission, that this can be predicting or estimating how it might look in areas where the transmission season is just starting. So that's it from my side. So Ingrid, if you can try again to share the video, otherwise we move to Thais. Ingrid?
Yep, I'm trying again.
We made you a host, so you're supposed to be able to. No,
we can't hear. No audio. Okay, so now let me give the floor to Thais dos Santos, who is a regional advisor for the Pan American Health Organization, and she's going to do a deep dive on the situation of chikungunya in the Americas. Thais, over to you.
Thank you so much, Diana, and good day to everyone online. It's a pleasure to be here with everyone. So Since 2010, PAHO, in collaboration with the CDC, had worked on guidelines to prepare for a possible introduction of chikungunya virus. And these guidelines were finally published in 2011, which was extremely timely because by 2013, it was the first detection of chikungunya in the region of the Americas in the island of St. Martin. By December of 2014, the virus had spread to most countries of the region, occurring over 1 million cases. As you can see here in the purple bars from 2014, there was over 1 million cases, 700,000 the following year, 671,000 the following year. And it's been going down for, in the decades since the virus has been in the region of the Americas. But in 2023 so far, 214,719 cases have been detected, of which 44% have been confirmed, and 124 deaths have been reported so far for a case fatality rate of 0.06%. When we look at how the numbers this year compare with previous year, if you see the chart on the left, you see in the blue line what the case counts were for 2022, which was an epidemic year. The country in the region that usually reports the highest number of arboviral disease cases, Brazil, had an epidemic year. So it was a year of intense chikungunya transmission, as it was, if you see how it compares with the yellow line, which is the 4-year average. And this year, as you can see in the red line, the cases have been of the magnitude of the cases is much higher, and also the timing and when the cases happen. They happen much earlier than the usual seasonality that we see for transmission of arboviral diseases in the region. So in 2023, we saw an increase of 128% with respect to the same week of 2022 and 264% with respect to the previous 4 years. And you can see that we have cases so far, 78,000 cases reported in Brazil, 10 deaths. Paraguay has reported the most cases with the worst chikungunya epidemic in history with 138,000 cases and 114 deaths. Uruguay has reported the first 7 cases of local transmission. Argentina is also reporting local transmission for the first time, reporting 776 cases. And Bolivia, who is also experiencing a concurrent dengue outbreak, is reporting 935 cases. So when we look at this, at this chart for Paraguay, the lines mean the same thing as they did in the first one. When we compare the cases against the cases in 2022 and the 4-year average, we can see a bump starting in 2022 in October. And this year, the magnitude of the epidemic is unlike anything that Paraguay had experienced before. When we see in the map on the right-hand side, you can see that there have been areas of intense transmission. You can see that little red dot where the capital, Asunción, is, and the central department, which is around Asunción. But there's still areas in the country that have not detected cases and where transmission has been reasonably low. So even though the outbreak is subsiding or slowing down in the capital and surrounding district, in the rest of the country, there's still transmission, and in some places increasing transmission. Most of the cases detected have been female. 57% of the cases are female. And when we look at the age distribution, we see that for males represented on the left in the blue bars, the cases tend to be a little younger than for females. Most of the cases are between 20 and 40 years of age. When we look at the deaths, I apologize, this graph is straight from the Ministry of Health of Paraguay, so that's why it's in Spanish. 115 deaths have been reported in this epidemic, of which 1 happened last year and 114 this year. The greatest number of deaths have been in males over 60, and the 18 deaths tragically have been reported in infants under 1 year old. The case fatality rate is 1.6, with the highest case fatality rates in those under 1 and those over 80 years old. When we look at the data for Bolivia, we also see that this year was unlike last year or the 4-year average. The same for Brazil. Note the shift in the seasonality here for Brazil. And in 2022, as you may recall, I just mentioned that it was an epidemic year, and even so, this year, the magnitude of cases and transmission is quite high. For Argentina, we don't have the historical data as you know, this is the first case of local transmission, but you can see clusters of blue around the greater Buenos Aires region, the capital, and also in the border areas with Paraguay, which is on the upper right-hand side of the map. So what has PAHO done to support countries? Well, so far, 7 technical missions have been deployed to Bolivia and Paraguay on clinical management, on epidemiology and surveillance, on lab, on integrated vector management. PAHO is also rolling out a strategy for collaborative surveillance where through the use of SharePoint spaces that we call virtual collaboration spaces, countries share their surveillance information, and through the help of a team of programmers, we help automate analysis so that it just automatically generates visualizations to facilitate decision making. And it's really like a hub that facilitates communication, collaboration, and the technical cooperation that we provide to countries. With regard to integrated vector management, among other strategies, our public health entomology program is launching a new strategy of risk mapping and risk stratification so that vector control interventions can be directed at the areas with the greatest need. And for training on clinical management, this has been really for us, somewhat surprising gap that we've been able to fill. We've trained so far this year thousands of clinicians on chikungunya clinical management, but since 2020 we launched a virtual course on dengue clinical management, and I include the links there for your perusal. A chikungunya virtual course is coming soon. This is a 20-hour course that provides a certificate once the participants are done. And so far we've had over 120,000 people take this course. So we're very hopeful that the chikungunya, which we hope will be coming in the next few weeks, will also engage as many people and hold interest as with the success that we've had with the dengue clinical management course. So finally, 2023 has presented increased arbovirus circulation. We've also, there's no time today, but to review this, but we've had intense dengue circulation in many countries in the Americas. And then several countries in the region are experiencing important increases in chikungunya transmission, with also an increase in deaths above what we'd seen in previous years. And as I mentioned earlier, we see a broadening of the seasonality and expansion of circulation to new areas where the virus hadn't circulated before. So then, the question I want to leave you with is this increased transmission in the Southern Hemisphere advance notice for Northern Hemisphere summer? And if so, then what are we doing to prepare? And also finally, new tools and technical cooperation, making use of virtual platforms especially, have demonstrated success in monitoring epidemics and mitigating the impact. And that's all I have. Thank you so much.
Thank you very much, Thais, for the detailed deep dive on the situation in the Americas. And now let me give the floor to Dr. Thomas Scott, who is a distinguished professor of mosquito-transmitted disease ecology and epidemiology at the University of California in the US. And he's also a member of the Technical Advisory Group on Arboviruses at WHO. So, Dr. Scott, over to you. Can you share your screen?
Okay, can you see it and hear me?
Yes, we can see your screen, we can hear you, but you are way ahead in the slide, so.
Yeah, there we go.
There you go, over to you.
Okay, thank you, Diana. I'm going to briefly provide some background information, then talk about entomological surveillance. Then I'll talk about vector control, some of the features of effective programs, and then details of how this can be carried out. And then I'll end with a brief discussion of strategies and tools that are in the development pipelines, the things that may be available in the future. Arboviruses, as we've already heard, are among the most important vector-borne pathogens in the 21st century. And Aedes transmitted viral diseases like chikungunya, dengue, Zika, and yellow fever are growing global threats. For over 100 years, vector control has been a primary method for preventing these diseases. And the concept for it is relatively straightforward. You reduce the mosquito populations, or you reduce their contact with humans, and then you reduce or prevent disease. And this can be highly effective, but it needs to be comprehensively applied and it needs to be sustained. And although there is progress and encouraging progress being made on development of vaccines for chikungunya and other Aedes transmitted viral diseases, vector control remains a primary and in some cases the only intervention that's currently available. In terms of surveillance, effective vector surveillance requires community engagement, social mobilization, and integration across sectors. Coordinated mapping of entomological, epidemiological, and environmental data, and so that requires coordination among the people that are collecting that information, can facilitate planning, implementation, monitoring, and evaluation of how well the vector control is working. Entomological surveillance should emphasize adult female mosquitoes because these are the ones that are primarily involved in transmission. There are a number of immature indices available, and they can be useful for assessing the impact of an intervention, but there's not good evidence indicating that they are good predictors of the risk of infection and disease in humans. So the emphasis really should be on adults. And there should be an insecticide resistance monitoring program. It's done routinely so that it can be mapped, and if it's detected, it can be managed. So what are some of the features of effective control programs? They're integrated combinations of interventions that are the most appropriate for the local situation. It's really unlikely that there's going to be a single intervention that'll be most effective across all ecological and epidemiological contexts. So you really need to understand the vectors in your location and the epidemiology and design a strategy that's best for your specific location. The program should simultaneously target immature and adult vectors with multiple interventions. And for outbreak prevention or for interrupting an outbreak, a comprehensive intervention delivery with high coverage that's sustainable is really critical. And that's hard to do. It requires a lot of attention and resources and personnel. And effective programs measure, analyze, and integrate entomological and epidemiological data so the people that are gathering that work, that kind of information, work closely together. Successful implementation and sustainability of disease prevention programs requires local and national government support and collaboration across sectors. But ultimately, in the long term, if this is going to be sustainable, it's going to require a coordinated regional approach. Now, one of the things that we could use in the future, it's not something that could be used to stop an impending epidemic, but something we can really start to think about is improving the built environment. There's already been some discussion about how particularly Aedes aegypti, which is an invasive species that's been introduced into urban environments where it's not naturally found, that's where it's thriving. So if we change the way we design houses to exclude mosquitoes, provide reliable piped water, solid waste removal, and things like how we store water, it not only could eliminate Aedes aegypti and prevent the viruses that it's transmitting, but it would improve public health all over. So it's something that in the long term could be more sustainable than trying to detect and respond to an impending epidemic. Current vector control, these are some recommendations that I would make. Use locally adapted and derived vector control. A single tool of strategies is not likely to be successful everywhere. Know your vector and its ecology. interventions that target Aedes aegypti should focus on indoor areas using residual insecticides. That's because Aedes aegypti rests primarily indoors. If there are other members of the Scutularis group, like Aedes albopictus or polonensis, that are involved, they have different behavior and ecology, and so you might need to think about different strategies for addressing them. You need to know the insecticide susceptibility of the local vector population, so that you can decide if you want to change or take a measure of monitoring or mitigating that. Most space sprays, which is something that has been used in the past, either aerial or on the ground, are relatively ineffective unless they're repeatedly delivered inside homes. And that's because they don't tend to reach the mosquito inside homes, and they have a low amount of time that are effective. So you have to do it inside homes and do it repeatedly. If that's done, it can be effective. A method that's currently being evaluated, I'll talk a little bit more about it in a minute, is targeted indoor residual spraying. It shows some promise for reducing Aedes transmitted viral diseases, and it is something that could be used in an impending epidemic. There's also novel delivery methods that are being developed that carry killing agents like insecticide-treated screens, curtains, and lethal overtraps. But again, it's something that needs to be applied comprehensively and maintained, and that can be challenging in large urban environments. And the last thing I would say is that adulticiding should not be done in isolation. It needs to be part of an integrated vector management plan, and particularly in partnership with larval control programs. So what are some of the things that are in the pipeline that perhaps could be useful in the future? And I think one of the biggest things is going to be to use combination of tools and strategies. And one of the things that is particularly appealing and encouraging would be to combine vector interventions, either insecticides or without insecticides, with vaccines when they become available. And there are theoretical reasons why this could be particularly interesting, and I can talk more about that if folks are interested. One of the challenges we have, however, is the details about exactly how to do this, so it's done in a location-specific way, is something that needs to be determined. There are new products, the ones listed here with the squares next to them, have been or are being evaluated in clinical trials. So Wolbachia had a very successful trial in Indonesia where they reduced illness in humans. There's also a trial that's ongoing now in Brazil. So for patient repellents, there was a trial in Peru that showed a reduction in infection, and there's another trial that's being planned for Sri Lanka. And for targeted indoor residual spraying, there's an ongoing trial currently in Mexico. Other things that are in the development pipeline that may be useful in the future are nets that are treated with chemicals, either a single or combination of products, vector traps for disease management, or sterile insect technique. But these are things that are not as far along as the first three that I mentioned. In terms of the impending epidemic, I would refer the participants in the meeting to this slide, which I think, although it's a brief overview, it hits the key points for responding to an impending epidemic. And I will end there. Thank you, Diana.
Thank you very much, Professor Scott. And well, we have 16 minutes for questions. We have already few questions in the Q&A, and please keep adding your questions there. So I have one for Thais from the PAHO region. So in 2023 is the year of El Niño. Could this contribute for chikungunya cases that have been occurring earlier this year? Thais, over to you.
I think that we don't fully understand the environmental drivers, but certainly there have been correlations found between El Niño years and transmission of arboviruses with dengue especially, and it's been a little bit less looked at for Zika and for chikungunya. But I think that what has become apparent is that we're having longer stretches of warmer periods further and further south. And I think that has enabled the mosquito to do well in places where the mosquito didn't do well before or had a reduced season. like for example, a country like Uruguay that hasn't traditionally had a lot of arbovirus transmission, and it still doesn't. But I think the fact that we've had local transmission is significant.
Thank you very much. Anything that you would like to add, Tom, about the question of El Nino or La Nina and how that can contribute to an increased densities on Aedes mosquitoes?
Yeah, that certainly could be an important issue. We published a paper with Moritz Kramer several years ago that looked at how changes in over time associated with climate might change the distribution, particularly of Aedes aegypti and Aedes albopictus. And what we concluded from that was that it might extend transmission periods, changes in climate, and it may change distribution where mosquitoes are found in some places, but it may also eliminate them from others as temperature rises. The other really critical point, I think, is the susceptibility of the human population. So if herd immunity is low and the different strains of virus that are introduced, that could also be a critical issue with regard to the outbreaks that we're seeing.
Thank you very much. Maria, you have your hand up. Over to you.
No, I just wanted, adding on to what Thais and Thomas have said, I think what this question illustrates is the changing dynamics of all of this. And both Thais and Thomas talked about this, the extension of transmission seasons and the duration of when these pathogens can transmit, but also the changing locations of where these vectors are. And I think that's true across the spectrum of pathogens that have this epidemic and pandemic potential. So there's a lot that we know about these pathogens, but there's a lot that's changing. And I think for those of us that work in that space, for people who work in country on surveillance, on prevention activities, we need to be open-minded to the changes that are happening because of things like climate change, but also the way we live on the planet, the way that populations are moving. And so we have to refresh our expectations of where this emergence, where these outbreaks may happen and when they may happen, and we have to be even that much more vigilant. It doesn't mean that everybody that's out there in the general population has to worry about this all the time, but we need to be more strategic of using the resources that we actually have to inform people, maybe do more on the risk communication side and the prevention and the vector control activities to try to ward off as much as possible. But it's a changing landscape.
Yes, absolutely. And with the current distribution of these vectors in the European region and even in North America, the risk is increasing. As Sylvie also mentioned, there is almost 4 billion people at risk, but that number is likely to increase in the upcoming years. So there are more questions here. Sylvie,
I would like just to add I would like to add one comment on this, because I think Professor Scott mentioned it as well. We need to have short-term response, because the climate, the Nino and Nina and other climatic phenomenon may have an impact. And so these are short-term increase in the risk. But also, as Professor Scott mentioned, I think it's important for us to understand that the condition driving those outbreaks are increasing as well and will continue to increase, meaning that we may have more of these outbreaks in the coming years. And it's good time as well to look at more long-term strategies, such as modifying, for example, urban settings, plans for in large cities to modify the habitat of human and have some kind of a preventive action that are not in the health sector, but can be done in other sectors than health, but will contribute to make the world a safer place for humans. And so I think this is also a very important connection to make in addition to the climate connections.
Thanks, Sylvie.
Can I follow up on that just briefly?
Absolutely.
That's an excellent point. In the short term, I mean, the kinds of changes that I mentioned, I only mentioned them briefly due to time in the urban environment. That's going to take a period of time to happen. But in the meantime, public health officials, people in political positions, and the people that are affected by these diseases want something to happen right now. So we really need to develop short-term plans where we maximize the public health impact, and then think about longer-term plans that will be more sustainable and have a broader impact, not just on the diseases we're talking about today, but improving public health in general.
Yes, absolutely. Thank you very much, Tom. And yes, definitely the multisectorial and the multidisciplinary approach are going to make all these activities more sustainable and actually make some changes in the urban settings. So let's go here with more questions. So is there anything different that needs to be done in vector control to prevent chikungunya compared to what we usually do with dengue and Zika prevention? I think this one is for you, Tom.
The things that I talked about are part of a update for, well, it specifically deals with dengue, but it deals with Aedes aegypti. So of course, Aedes aegypti-borne chikungunya that's currently under review at WHO. And I think when that becomes available, we'll see that there are some changes like emphasis on adult monitoring as opposed to larval indices, specific tools that we have for controlling Aedes aegypti and reducing disease. The one thing to think about, Diana, I think you or others may have mentioned it, is, for example, Aedes albopictus and the role that it may play, for example, in Europe if chikungunya was introduced. That might be different than a different set of strategies than the ones that we use for Aedes aegypti, which is primarily, though not exclusively, attacking them inside homes.
Thank you very much. And there is a question here for Thais. How is the regional approach currently coordinated in the Americas? Thais, over to you.
I think that this follows the same pattern that we do with many of these pathogens. We did so with pandemic influenza and with chikungunya in the past, where we have countries that have more experience dealing with these epidemics, assisting countries that do not. So, for example, the virus was genotyped in Paraguay, and a delegation from Brazil that has a lot of experience doing this was sent to Paraguay to assist in this process and build capacity in the process of doing so. Similarly, clinicians that have a lot of experience in these infections, and pediatricians and infectious disease experts have been deployed to Bolivia and Paraguay to do training locally of clinicians facing the epidemic now. So, we obviously regionally monitor the epidemic. So we look at the data of the progressing epidemic, but we also coordinate this sort of country to country capacity building. And all of this obviously under the framework of the integrated management strategy of arbovirus prevention and control, which is kind of our guiding principles in the region. Thank you.
Thank you very much, Thais. I see a question here about, you're interested to hear more about vaccine development for chikungunya. So I'm going to reply to that one. So there are about 7 vaccines that are currently in development, and 3 of them are finishing phase 3 trials for the chikungunya vaccine, which are great news. We have 2 live attenuated vaccines and 1 inactivated vaccine that are going to apply for licensure in the upcoming months or even in the next couple of years. So there is hope there. And there is 1 vaccine also live attenuated that is in phase 2, and there are with different technologies 3 other vaccines that are in phase 1. So I think there is hope there. I didn't mention this before, but chikungunya is part of the list of priority pathogens for the research and development blueprint, not because of the case fatality rate, but because of the disabilities that causes in the population. So we are currently working with the immunization, vaccines, and biological departments and with other departments within WHO to start working ahead on which will be the vaccine profile and which will be potentially be the strategies to introduce these vaccines in different areas in the world.
Diana, can I just comment on that as well? Because I like that the question and the vaccines were brought up, because I think what we've seen in recent years is that the development of these vaccines takes time, and that they're built on long-standing relationships. And that's why we have the R&D blueprint for epidemics, you know, and identifying these priority pathogens. COVID was the latest example of a vaccine that was developed very quickly once we had the full genome sequence, but that really started years ago. And we need investment in this area, and investment in vaccines for chikungunya remain critically important. We need the funding and the emphasis to be on that. But also that we've seen that research can be conducted in outbreak situations, particularly when pathogens are infrequent or they're hard to detect. So we like to see that as part of response, because it is an opportunity to learn and to see how these interventions can be used safely, effectively, and within communities and by communities. So there's a lot of work that's been happening in this space, and we need that investment for chikungunya as well.
Yes, absolutely, Maria. Thank you for that comment. There is another question here for Tom, and it's about the person would like to hear more about how to best combine vaccines and vector control, and how to combine Wolbachia with vaccines and some other strategies, keeping the approach of the integrated vector management. Over to you.
Okay, so the idea of combining vector control with the vaccine is that these two strategies complement one another. So the goal of vector control is to reduce the force of infection. And on the long term, that can be a difficult thing to do. If you get really good at reducing infection, then by recruitment of birth of susceptibles, you actually have a decrease in herd immunity, where it can get to the point where even with very low mosquito densities, you could have an outbreak. And that's exactly what we've seen in Singapore, where they had a successful program. On the other hand, vaccines can protect an individual, but they can also, depending on the vaccine and its characteristics, elevate herd immunity. So what vector control does is it reduces the force of infection. So in terms of calculating what proportion of the population you need to vaccinate, it makes that easier. And the vaccine artificially elevates herd immunity, and it makes vector control more sustainable. So the two things together can theoretically be quite effective. There was a study that was published recently. It was a modeling study. And basically what they concluded is it depends on the characteristics of the two interventions. That's a really important thing. So we need to work out the details of how something like this could be done. But the point that I would want to make is that there's reason to believe that they really could be quite helpful working together, and we don't need to think about just using one or the other. And in terms of Wolbachia, Wolbachia basically is reducing the portion of the population that are competent vectors, at least if you're using it from the point of view of not just reducing populations, but like the trial that was done in Indonesia. So it's essentially the same thing as reducing the population density of the mosquitoes. So in that way, I think it would be similar. So it's encouraging there. I think I completely agree. We need to have significantly more investment in chikungunya vaccines. The current outbreak is an opportunity to do a phase 3 trial in an endemic setting, which is difficult for viruses that only show up periodically. We really need to further develop vaccines for all of these viruses, but also think about how we can use them and how we can use these vector control and vaccines together. I hope that answers the question.
Yes, thank you very much. And it's exactly a similar approach to what we saw before with COVID-19, that there is not just one intervention is not enough. You need to combine to actually have an impact. Sylvie, over to you.
No, I think that we are reaching the hour, I think. So I just wanted to reiterate what Jiangfeng has put in the chat. That's the presentation and the material will be available on the EPI-WIN website. And that also, if people want to be informed about future webinars and topics, they can also connect and engage into, and Langfeng has provided the link so people can subscribe and then be in our list of invitees. So I just wanted to make sure that people have seen it because the chat is very busy. There are a lot of comments, which is fantastic. But then those kind of messages can be hidden below the pile. And so just to highlight that people can find this, and maybe Jiangfeng can resend so that everybody can see it.
Thank you,
Thank you
Sylvie,
very
for that
much.
kind reminder. Over to Diana. Maybe we can take one more question because yes, but we started a little bit late, so there are many good questions. Diana, over to you, maybe for one or maybe two, just if we still have people online. Please go ahead.
Okay, so I have a question here for Thais. The data from Paraguay indicated some interesting age-sex distribution for case and fatalities. Are these also seen across other regions, or have you seen this before in previous epidemics when the introduction in 2013 and 2014 of chikungunya in the Americas? Or is this an emerging issue? Over to you, Thais.
Yeah, I think some things hold from previous epidemics in the region. For example, the fact that the cases are predominantly women, which may represent that there is something about the exposures within the household that women have differentially, or a more likely answer is that women have different health-seeking behavior than men and are more likely to be picked up by the surveillance system. So, but we do see this in previous epidemics where there are more women than men. That being said, just like in previous epidemics, we do see mostly men dying from this disease. Something that was a little different about this epidemic was the number of infants, excuse me, that have sadly passed away. And there were just both in mother-to-child transmission during birth of viremic mothers, but also newborns that got infected soon after birth by the usual mosquito transmission. So this was unlike what we had seen in the past. But the deaths, the risk factors for deaths, persons with comorbidities, those are all things that have been previously documented in previous epidemics. Thank you.
Thank you very much. So yes, the neonatal chikungunya have been reported in different outbreaks. However, the larger the outbreak, the larger the possibilities that you're going to have pregnant women that are going to get infected, and then that might pass the virus while delivering the babies and then having neonatal chikungunya. So that's an issue. And also an important thing to highlight is that the health system this really collapses the health systems because there is a higher need of neonatal ICUs and also ICUs for the adults. So one last question. Which are the vector control approaches are more suitable and sustainable in low-income communities? Tom, over to you. Last question.
I think one of the things that's really critical is to engage those communities. And so it's very important to have, as I indicated in my slides, to have people with a background who understand how to contact and work closely with those people in those types of communities, and then to identify with regard to what the ecology of the local mosquitoes is and the epidemiology. We heard how there are efforts underway right now to identify hotspots so that you can target resources in those locations to develop a plan or a strategy to address that. I don't think that they would differ dramatically. You want to do some sort of reduction in the development of the mosquitoes, so larval reduction, and then in an epidemic setting, really try to get whatever the intervention is inside the house to kill the adults. Now, the logistics of how you go about that and how you communicate with people are going to have to be tailored for that specific situation. So you really need to have people that understand how to do that and how to communicate effectively. Oftentimes, these programs are not resourced the way that they should be. And that's something where we really need political support to make that happen. And it can't be something where we just put money in that direction when there's an epidemic, and then when there isn't, that funding goes away, and then the people that are trained to do that work move on to other jobs. There needs to be a sustainable effort in that regard, which gets back to my point before. What's the long-term solution to this going to be, and how are we going to combine that with the short-term solution, and how are we going to make the transition from really, it's hard to control Aedes-borne infections because Aedes aegypti is such an efficient vector. So you really need to do it well. You need to do it over a large area. How can we improve the use of the tools we have right now and then transition into a more sustainable long-term solution? I think that's a critical question. I'm part of a Lancet commission that is specifically looking at this, and hopefully by the end of the year or the beginning of next year, we'll have a manuscript that would describe it.
Thank you very much, Tom, and thank you very much, Saiz, and all the speakers. Over to you, Juvika, for the closing words.
Thank you very much to you, Diana, for great moderation. Yes, thank you all. Thank you especially for Thomas and Thais, because they did wake up early for this webinar. Thank you very, very much for all the participants. Of course, Diana, Sylvie, Maria, and all the EPI-WIN team behind the organization of this webinar, Supriya, Priya, John Fang. And we are really looking forward to seeing you on the next one. And as I said, this is just the first one in the series of parvovirosis webinars that we are planning to organize. So we are looking forward to seeing you again and the next one. So have a great afternoon, night, or day, and see you again soon. Goodbye, everyone.
Thank you. Bye.